Okay, thank you, Dhanasri. I think you are a VR surgeon and you will be in favor of us. Your first slide, you said it is a blinder. If you see the fundus photograph, by itself speaks that you cannot see such a clear fundus with macular edema. So with such a kind of a cataract, you cannot assess what is the type of macular edema you are dealing with in diabetics. So degree of cataract is very, very essential. And these days, majority of the cataracts are 6-9 cataracts or even 6-6. I wonder why they do the cataract surgery at the first place. Such a case, you can easily assess what the type of diabetic macular edema you are going to deal with. And if you such a media clarity, if you are not handling the diabetic macular edema, probably what you said can happen, that after cataract surgery, there can be a worsening of diabetic macular edema. That is my first point. Second point, in which cases you are going to give the anti-VEGF injections. If you see non-center involving macular edema, still I practice a focal or grid laser in areas of leakage rather than anti-VEGF injections, because single sitting laser will resolve for longer time. You also clearly know that vitreomacular traction is not a case for anti-VEGF injections. In addition, ischemic maculopathy, you should not deal with it. Whereas only focal or diffuse leakage, you go for anti-VEGF injections. And if you see the pre-existing diabetic macular edema shall be treated before cataract surgery rather than simultaneous. You dry the macula, go for cataract rather than leaving it wet. And subjects without pre-diabetic retinopathy changes are less likely to progress. So these cases do not require a simultaneous anti-VEGF injections. This very paper you also had quoted. So, and in cases where there is a concurrent central involving diabetic macular edema or non-center involving diabetic macular edema, which are preoperatively, if they are present, they are the high-risk cases for center involving in the post-operative period after cataract surgery. So you need to treat them before going for cataract surgery rather than going for a simultaneous anti-VEGF injections. So my take on diabetic macular edema is one need to have a progression of diabetic retinopathy in mind while performing the cataract surgery. A high-class cataract surgery would not lead to worsening of diabetic macular retinopathy. You need to understand that. No diabetic retinopathy or stable treated diabetic retinopathy they are likely to remain stable after cataract surgery. So no need for intervention or simultaneous intravitreal injections. And intravitreal injections will not be useful in ischemic maculopathy, I already told you. And macular edema tend to worsen after cataract surgery only if it is active. So make it dry before you think of simultaneous injections. Simultaneous anti-VEGF injections therefore warranted only in limited cases. And if macula is dry, it is not indicated. And immediate post-operative assessment is just sufficient for us to decide whether they require anti-VEGF injections or not. And if it is wet, you treat immediate post-operative without wasting any time. Why to go for simultaneous anti-VEGF injections, which may unnecessarily be given if you are not assessing at proper time. So very limited and narrow spectrum of indications for simultaneous anti-VEGF injections along with cataract surgery. We should not go into that era. So more ideal and preferred care is to assess the type of macular edema and treat accordingly either before or early postoperative period rather than simultaneous. I hope you agree with me, Dhanasri, as a VR surgeon. Thank you. This is the last slide I have.
Thank you very much, Dr. Ajit Babu. You can stop sharing. Dhanasri, you would like to say something?
Yeah, sure. So I fully agree with you, sir, Dr. Machi, that you can probably stabilize the patient, whatever before and
Yeah.
after. But here we are debating about a patient who is in need of anti-VEGF. We are not talking about stable maculopathy or patient who has a non-center involving DME or who can be treated with laser. We are talking about a patient who has DME and who has cataract. And what would we like to do with them, whether we treat the same sitting or different sitting? So my
My
take is that
message is to
why
the
go.
cataract surgeons, not to you. I know that. That's why I'm very clearly told it is for the cataract surgeons.
Okay.
So we should not give a message that simultaneous will help them.
So the cataract surgeon can take help of the VR surgeon. We are always there ready to help them. I'm talking about the patient convenience. So it's really convenient for the patient if it is done in the same sitting. Now, especially with this COVID era, you don't want the patient to come again and again to the hospital once for surgery and then again for another injection. So it's quite a hassle. I think better we can finish it both in same sitting. Thank you.
Muna, please take on.
Yeah, excellent presentations from both, and the fact that they were so convinced about their topics, everyone finished well within time. And points very well taken on both sides. Dhanush gave us an example where cataract was, yes, I admit, a little more significant than one
That
would.
was just for illustration. Yeah.
But yes,
You can take
definitely,
another patient with less cataract. It's just
You said blind also, you are blind. Okay. Such
I
a
just
cataract.
wanted to impress upon the necessity for cataract surgery.
I know.
So you can argue that this patient doesn't need cataract surgery. So I wanted to show a photo which actually there is no argument. Cataract surgery is required.
We are all
Yeah,
pushed
yeah.
over.
yes,
That's okay.
so
Our care is
definitely
also bad.
when the cataract is dense enough that you get a clue that there is macular edema, but you cannot do much beyond maybe a CT which tells you there is significant macular edema. Definitely, it would be a good situation, more practical to treat both. But looking at that is Dhanashree's side of the argument, fully that is well taken and definitely a situation where you would like to do it. But look at a patient who has cataract, not so much, maybe needs macular edema treatment or not. I think most of us would agree that we would like to stabilize the macula before we proceed. So both of them have their courses. And if you have a patient who is on treatment for macular edema, develops cataract along the way, definitely I would think it's more practical to both at the same time. But if it's the first time you see the patient, you can assess the macula well enough, then definitely I would go with treating the macular edema first and then. So I think both talks made their point very clear that there are specific situations where you would like to treat separately and where you would like to treat together. So I think the messages come out very clear from this debate.